So this is like a really, really good friend of mine, Carlos Gonzalez. I met him first when we were both bio majors at Sonoma State, and then we worked together at the California Department of Public Health, and he trained me on the West Nile virus surveillance program, taught me everything I know about microbiology.
My name is Carlos Gonzalez. I am a public health microbiologist. I am working right now at the Sonoma County Public Health Laboratory. And we are here in our BSL-3, where we are testing for the COVID-19 assay.
What's a BSL-3? Can you explain what that means?
It is a contained negative pressure and restricted access laboratory. So it means that you have to have certain permission and clearances to walk in here, because we are working with potential dangerous agents or viruses or bacteria. So you need to remember, we are not testing just for COVID-19 on our facilities. Besides the emergency that we're facing, we are also working with anything else that public health needs, any other outbreaks that they may be out there, or respiratory viruses, etc., etc.
Would you be down to give us like a little tour of the lab? And I think there's been lots of questions about specifically, what does a test look like for COVID? Yeah, can you show us around?
All right, so let me see if I can do that. So this is just part of the lab. We have another section of the lab outside where we receive our specimens, and where people will come, different couriers, different clinics, hospitals, public health nursing. And there is another group of people who will be just dealing with accessioning our work, accessioning our samples, paperwork, entering to our computer system, etc. So where we are right now, and I got to turn around the phone, it is BSL-3. As you can see, what we have here is different hoods where we are setting up our extractions. Machine right here is an extractor, it's a kayak cube. So what it does, it's working on taking the sample that we receive and taking the nucleic acid out of the matrix. So what we mostly get is nasopharyngeal swabs.
Can you say, like, what's a nasopharyngeal swab? And like, who sends you samples? Like, where do you get samples from?
So right now we are getting samples from community clinics, for example. There will be different hospitals in the area that we service, that they will be bringing those samples. They send it to us because they are priority. We are not the only lab that does this testing, of course. There will be commercial labs that do bigger amounts, but we are in charge of the more critical testing, perhaps would be the word to be used. And that's who they bring, who brings the sample to us. A nasopharyngeal swab, which is right now the preferred sample for this testing, is as the name says, it's a swab. It's taken on the nasopharyngeal area. It's not on your nose. It has to go all the way back. It's not a comfortable test to take. So also, it's better to have a professional do it, like a trained nurse or doctor who knows what to do. And that is because we need to definitely have a good sample. Otherwise, the test is as good as the sample that we receive. So we have 2 machines going.
Cool.
And then we have another extractor platform. They are all being authorized by CDC and FDA. These are not the only extraction platforms that are authorized right now.
Cool.
But that's what we have here. And that's what we work with.
Cool.
And now, this is our baby.
Let's go. Yeah, what is that? Explain it. Yes.
So this is a ABI 7500 DX. It is a PCR, real-time PCR analyzer. So this is the working horse of pretty much any lab right now across the United States. It works with place on 96 wells. So, but because we are testing, in this case, for COVID-19, for 3 targets, we can test only 29 samples because we also have to, we also need to create a plate that includes 3 different quality controls.
Cool.
So
right now 8 different strains that have been identified. So do you guys do do you do sequencing for those 8, or do you do like 3 different, it sounds like there's 3. So then do those 3 sequences have like commonalities in the sequence?
you're right. It is the third target identified that is a human sample.
Got it.
The first 2 targets called N1 and N2 are common targets for the 8 different strains that have been observed.
And then what's the N3? What's the third one?
RMP.
What's that?
What it means is like the sample, any sample take from a human will come with that.
Got it.
So
Okay.
what it represents for us is that the moment that we run it and it says, oh, there is no RMP on this sample. What it will indicate to us is the sample wasn't taken correctly. There was degradation on the sample or in transit, or it was not extracted properly. So we will have to do different things to remedy that.
Okay, cool. Are you guys seeing like an uptick in samples that you're processing right now, or is it just like you're at full capacity every single day right now?
We have seen an uptake over time. Our lab, we do the testing. We are not taking samples. We are not accepting patients here and taking the samples.
Yeah.
And that's a differentiation that people need to understand, and perhaps your students will be great communicators for this.
Yes.
Testing capacity is there, and as hard as it is, limited equipment that we have. But the main limitation right now for a global coverage in California at least is sample testing kits. Specimen obtaining kits, which is a swab, it is a universal transfer media, and a tube. Something that as simple as that, right now we've been like really, really stingy with who can take what. And we are able, for example, a couple days ago, we were able to test around 130 samples in one day.
Wow.
So if it gets here, we are able to test it. As hard as it is and as long as it takes, but we are always working on trying to do a turnaround time of less than 24 hours. And so far we've been on targets.
That's okay. That's so cool to hear, because like it's also like something that like conversations that I've been having with my students, that it's like the media tends to like black and white things, and I think that the real story is very gray and like nuanced, you know. And like I was listening to Governor Newsom talk about how like there was a shortage in like the reagents that go into the mix tube, like for the kits, the testing kits, and that was like the first real big hiccup.
Those shortages are still there. We're being diligently like working, like big part of the work, for example, of John is to be emailing the different suppliers and the federal government, hey, we need more kits, because there is like different sources for different products, and right now extraction supplies are limited. Not everybody has them. We've been lucky enough that we still have enough for maybe like a week. Maybe less, depends on how it gets this coming week. So that's where we stand, and that's what we work with.
So then once you run samples, then like who do you obviously you push out the data to the person that was like asking for results, but like is there a database that like people can access to see like as live as possible numbers for the county, or like where do you push out your data, and then like can people find that data if they wanted to?
There is not an open public data
Got it.
based on reasons of privacy,
Yeah.
patient privacy. There is HIPAA, which is a law that authorizes just minimum exchange of information. Now, all testing, both negative samples and positive samples that we receive, we report those to the state, and the state eventually reports to the CDC. That's why you will see different numbers changing across the
That's
nation.
crazy. So like, the Johns Hopkins map that everyone's like looking at, is that data from the CDC then that they're pulling?
I think they use that. They have a link to it.
Yeah. Okay. I'll check that out.
That's part of what we do, and like we are creating those numbers.
Yeah.
And public health, nursing, and infectious disease units for different counties will have more information. And as far as I know, they have that information available to public in regards of, okay, in this county we have this many positive, this many people have been tested, and how many have been tested negative.
I just personally want to say thank you, and I'm like, really grateful for you, like as a human being and obviously as my friend.
We appreciate any support. There are several articles right now in the news because public health news, public health has become a talking point. I think I have repeated that to you before.
Yeah.
You never heard about public health because we do our job.
Yeah.
It is in situations like this when people start listening or talking more about public health. You must remember in the past 20 years, we have lost over a quarter of our public health laboratories in the state of California. And that has a real impact on situation of preparedness levels for a situation like this.
Yeah.
And that's why, for example, in our county, we serve also the counties of Lake and Mendocino because there have been decisions made on those areas not to have a public health laboratory. We understand there is a cost of this, but as we can see, there is a much larger cost associated with having that disparity on care.
Yeah.
And I appreciate it.
Yeah, thank you.
Tell them to always question everything.
Yeah.
That's what makes people.
Yes, let's go. Thank you for saying that. Let's go. Yes. I'll talk to you later, but thank you so much.
Aloha.
Okay, ciao.
Don't touch your face. Bye.
Bye.